Everybody hear me okay? Well, it's such a pleasure to be here. Thank you for inviting me. As she said, my name is Caroline, and I see so many familiar faces and new. I'm happy to be back in my old stomping grounds of the state of Iowa. So we'll just dive right in since we're running a little late. First with the disclosures. So I want to thank Midwest Area, who's a collaborative partner, who's offered an honorarium for this lecture. I'm just included today to be here with you, so thank you for inviting me. I will first start out with objectives for today's discussion. I do want to create a little bit of a content disclosure. I gave this talk recently in Arkansas to the Arkansas Medical and Dental Board, and they had an initiative related to maternal health disparities, so we gave this talk. So I tried to tailor it to Iowa and the state, but please note that when I made these slides originally, we were not facing the longest government shutdown in the history of our country, and so I never like to come across as tone deaf, right? So a lot of the content in this speech you might think, wow, this is weird timing. I mean, I totally recognize that, but I think it underscores the importance of, relying on community and fierce advocacy for access to nutrition, because without access, we can't promote good nutrition in general. So that's all I'll say there. Today, we're going to identify maternal and infant health disparities in the U.S. We're going to highlight some clinical interventions aimed at bridging gaps. We'll discuss the key role of maternal nutrition as it relates to overall health outcomes, describe general nutrition requirements of pregnant and lactating mothers, as well as discover nutrition-based solutions with an emphasis on dairy to improve health outcomes. So I want to first open up my talk today with this important graph, and I will say that when I first saw this statistic, I couldn't unsee it, as they said. I was forever changed. And what this graph depicts is that the United States has one of the highest maternal mortality rates amongst developed nations, and we've seen a sharp increase in this disparity since the COVID-19 pandemic. And unfortunately, this disparity disproportionately affects Black women. And as we know, the reasons behind the statistic are definitely multifactorial, and it's important to address the multitude of factors when we are analyzing opportunities for solutions. We must acknowledge patient factors, things like age, education, insurance, whether or not that is available to the patient, their poverty level, whether or not they're married, their literacy when it comes to health and otherwise, self-efficacy, all of those factors play a role. We live in a country where your zip code directly correlates to your health outcomes. And so where you live, the neighborhood, your social network, the crime rate has a direct impact on health. There are also provider factors, which I think are important to note. Things like our cultural competence, which I know this event will highlight in several talks, as well as our communication and ability to communicate with people from different cultures. And then, of course, we must underline systemic factors, which I think potentially are the most important at play. And as we evaluate these factors, we must discuss them at every stage of perinatal care: preconception, antenatal care, delivery and hospital care, and postpartum care. As a PA and dietitian, I maintain both credentials. I've worked in several specialty areas, but most recently I worked in endocrinology, and I worked alongside maternal fetal medicine specialists to manage high-risk pregnancies, so working on management of gestational diabetes and thyroid concerns during pregnancy, and worked in a very high critical access area, and so this concept and this topic is near and dear to my heart. As I mentioned, this disparity disproportionately affects static non-Hispanic Black women, and in 2021, the CDC determined that the mortality rate for Black women was 69.9 deaths per 100,000 live births. That is 2.6 times the rate of white women. And even more startling statistic, which I think people don't realize, is that 80% of these maternal deaths are actually preventable. Now, there have been many national, tangible clinical public health interventions that have been started within recent years, namely the CDC's Perinatal Quality Collaborative. Here are some examples of their programs. There's the HERE campaign, which is focused on more direct patient information. Here's an example of a handout. So essentially, they're gearing this information towards self-screening, where patients themselves are educated on what high-risk may see a hypertensive crises during pregnancy, but obviously this just scratches the surface. I wanted to kind of shed light at a local level here, and I think it's important to kind of call out the elephant in the room, and that is that Iowa is not immune to maternal health disparities. 50%, more than 50%, 57% of counties in Iowa do not have an obstetric facility. Are we aware of that? And there are only 3.3 OB-GYNs per 10,000 women in the state of Iowa. And 14% of women in the state do not have a birthing hospital within 30 minutes of them, compared to 9.7% nationwide. And 11.3% of all births occur in maternity shortage areas. Now, there are obviously many reasons why these statistics exist. One is brain drain. Trained professionals, whether from U or Iowa State, decide to leave after degree completion. There are actually fewer facilities now in 2025. Actually, 40 birthing unit closures were closed down across Iowa over the past 4 years. There's obviously an increased level of medical complexity amongst our patients. One of the attending physicians I worked with in the hospital most recently said, back in residency, things were zebras, right? Zebras, medical diagnoses, which we'd never see. Now every patient is a zebra, based on that level of complexity. And then obviously it's important to acknowledge the financial burden. I'll just call it as it is. Birthing centers are unfortunately a profit loss, and so that affects the bottom line. Now, despite these startling statistics, there have been local initiatives that have been underway, namely the 2025 University of Iowa collaboration to work toward creating more family medicine, OB fellowship programs, OB-GYN residency programs for rural physicians, and midwifery programs, which is wonderful, and they are undergoing monthly outreach to rural areas. There's a healthy pregnancy program, which is allotted statewide funding for community agencies to provide things like lactation support, case management, etc. We have the Healthy Start Consortia run by local initiatives like Every Step, which has different locations around the state. And then there's the Iowa Prenatal Quality Care Initiative, supported by Iowa DHHS. One thing that I find neat about their program is that they actually have simulation videos for physicians to see, which have simulator robot patients where they play out high-risk situations, such as like shoulder dystocia or scenarios where we have to convert from vaginal to cesarean birth quickly. And I will say too, this isn't just Iowa, right? Minnesota, where I come from now, is also facing similar disparities, and so I don't want to point the finger necessarily, but I think it's important to highlight this. So obviously I'm speaking to the choir by saying this, but I think it's important that we focus on nutrition, because this is something we can control. Of the multiple risk factors associated with poor health in Black Americans, improving diet quality is one of the most readily modifiable and effective methods for improving health outcomes across the lifespan. We all are very well versed in dietary guidelines for Americans. I know we're all anticipating the new release version soon, but that these provide evidence-based recommendations for healthy eating patterns, which aim to prevent chronic diseases and promote overall health. And we also know that Americans aren't following them, right? Fewer than 10% of Americans follow these guidelines, with only 12.3% of adults meeting daily food intake and 10% of adults meeting daily recommended vegetable intake. And we can see that this holds true amongst different racial groups. We can compare that of Black U.S. Americans and that of non-Hispanic white Americans, and you can see those intake numbers there. When it comes to making a real impact, I think when we think about us as dietitians, what role do we play? Where do we step in? I think we would benefit from following the words of Rafael Escamilla and focus on the fact that the first 1,000 days of life, when we frame our minds around nutrition, is so important, because this affects the nutritional status of pregnant mothers. And really, these 1,000 days, if we frame our mind around this time frame, this begins at truly conception. And so it's important to focus on the health of the pregnant mother. And I just want to say, I know I'm speaking to the choir here, but we need to go beyond just start your prenatal vitamin in terms of nutrition recommendations as it relates to pregnant women. As I said, adequate nutrition within the first 1,000 days is vital. Defined as conception to the first 2 years of life, we must give special consideration to key nutrients that support growth and development during this critical phase. Things like iodine, folate, choline. You can see here across the lifespan between 0 to 6 months, up to 12 months, how dairy can really create, be a source of many of these nutrients. Preventing maternal malnutrition is critical to improving maternal and child health, and to do this, pregnant women need to meet additional dietary needs through the intake of nutrient-rich foods rather than energy-dense foods. And here we can see the increased caloric requirements based on the state of the mother during her pregnancy and beyond during the lactation phase. So we all know that as the trimesters progress, we require more caloric intake. So when it comes to the role of dairy food consumption on the maternal nutrition status, I find that 90% of mothers in the U.S. fall short of recommended dairy intake. It's a huge statistic, 90%. However, recent NPAS analysis revealed that pregnant women who consume greater or equal to 3 servings per day are more likely to have higher intakes of all of these important nutrients for growth. Incorporating dairy foods has been linked to better maternal health outcomes like healthy gestational weight gain, reduced risk of gestational diabetes, which I worked so hard to manage in many of our mothers. Intake of calcium and magnesium reduces risk of pregnancy-related hypertensive disorders, and maternal consumption of dairy is associated with higher DHA omega-3 to omega-6 ratios in utero. And as you can see here, just 1 glass of dairy provides 13 essential nutrients for the pregnant mother and her growing baby. Iodine has gotten a lot of been put in the spotlight recently as it relates to research within the gestational period. It's essential for the production of maternal and fetal thyroid hormones, and inadequate intake can increase infant mortality, and it can potentially reduce infant IQ later in life, obviously. 1 glass of milk provides over half of a pregnant woman's daily iodine needs. So you can see here are the recommended amounts, adequate intake in pregnancy, and you can see as it relates to breastfeeding slightly more. Choline, we all understand the importance of choline during pregnancy. This is an essential nutrient and methyl donor needed for metabolic functions in the body. Higher consumption protects against neural tube defects and enhances neurocognitive development. You can see here the recommendations, about 440 to 1,000 milligrams a day, supports fetal development and improves pregnancy outcomes. The average choline intake during pregnancy is only 70% of the adequate intake. And you can see here, 1 cup of milk actually provides 43 milligrams. So not too bad in terms of making a dent in the daily requirement. Lactation is a passion of mine. I myself am not a lactation counselor, but I work very closely with many. And we know that currently there are fewer Black mother-infant dyads who breastfeed as it compares to white mother-infant dyads, about 74 versus 85%. We know that Black mothers tend to discontinue breastfeeding earlier than that of other racial and ethnic groups, and this contributes to over 3-fold risk for conditions like necrotizing enterocolitis and over a 2-fold increased risk for infant mortality as compared to that of other populations. When we're studying the impact of maternal diet and lactation, this is really something that's quite challenging to do. Studying the relationship between maternal diet and how that affects milk directly is hard because it's based on the fact truly that milk and the composition itself is not constant. It changes from the morning to the night. There's melatonin at different times of the day versus others. And so this kind of dynamic nature and constant change makes it a little bit hard to encapsulate that in a research setting. But we do know that intake of dairy foods during lactation may reduce incidence of food allergy, particularly by 12 months of age, and hopefully anyone working in the pediatric space is well versed in really landmark trials that have shown earlier introduction of those allergenic foods can reduce risk. I'll start to wind down the talk today talking about where we can be rooted in further opportunity. I think in the Midwest particularly, we we have a particular, I think, population that is inclined to pursue dietetics. We know that only 3% of US-based registered dietitians identify as Black, and it's crucial to continue to support this to increase diversity in medicine and healthcare at large. It's important to remind ourselves to actively engage and meet with our patients where they are at. We should always keep in mind that cultural staples do indeed fit into the mind plate paradigm, and so really taking on this sense of inclusion as it relates to our nutrition recommendations is so important. Here I have a friend, her Instagram handle is Black Nutritionist. She allowed me to share this cultural plate, as well as my friend Rocco, who works as a sports nutrition professional and really works on working with his Hispanic population group to provide good nutrition recommendations that are culturally inclusive. So some key takeaways and evidence-based recommendations. At only 60 cents per day for 3 servings, dairy is a cost-effective way to enhance the diet and quality of Black Americans, particularly pregnant and lactating women. Adequate dairy food consumption reduces health disparities and reduces incidence of negative pregnancy outcomes. And of course, education on appropriate nutrient-dense, culturally relevant foods should be prioritized during pregnancy and lactation. And I'll end with this important quote from Serena Williams, who spoke on her personal experience with maternal complications. The greatest threat to a woman's life in childbirth is not her body, it's the system that does not listen to her. I'm happy to connect more offline, or online rather, so I'm happy to continue the conversation, and thanks for having me today.
Hi, Caroline. I have a question about dairy consumption during breastfeeding. I don't think I'm probably alone in either experiencing myself or hearing that there are a lot of providers that immediately encourage breastfeeding moms to eliminate dairy if their babies are fussy or having GI discomfort. What are your thoughts on that? And it's been a while since I breastfed babies, but is that still something that's widely recommended?
No, it is not widely recommended, although you will hear that often, and I think there's this immediate kind of finger pointing at ourselves, like I'm the failure, I must change something, where we completely forget to acknowledge the fact that normal physiology is at play of a growing infant GI tract. It is so evident that stools change. You might see some blood in the stool one day and not the other day. We shouldn't immediately jump to think, oh, this is CMPA, cow's milk protein allergy. We know that with that growing GI tract, things change from day to day, week to week. And so I know this is a bit controversial, but watchful waiting does have an approach in medicine, and it does have a role. And so I think reassurance is the biggest thing that we overlook in medicine. And I think there's value to providing reassurance, and I think that's one way in which dietitians can step in as the nutrition experts and really play a role in sharing with mothers. There's so many other reasons why babies can be fussy, have reflux, colic, and thinking about position therapy changes, maybe slowing down feeds, working with a lactation consultant if you're breastfeeding. Bottle feeding, the recommendations are slightly different, but jumping right away to such a drastic change in diet, which, as we've seen, can immediately impact and directly impact the nutrition adequacy of the lactating mother. We know the requirements are sky high in lactation as compared to pregnancy. So I hope that answers your question. Long story long, no, but we'll see it happen a lot. Yeah, question up front.
Yeah, do you know any research or your thoughts on the effect of doulas on maternal care?
I'm so glad you brought that up. She asks about research on doulas. Off the top of my head, I can't think of like an exact study that I can name, but yes, doulas have an incredible impact. I think they're wonderful. Looks like somebody raised their hand up top, or maybe, you know.
I had a question, but I had.
Yes. When I was down in Arkansas working with their group, they actually have an initiative focused solely on doulas, and their outcomes have been incredible. So the AMD DPA, I believe, is the group that acronym right. And yes, to answer your question, doulas are an incredible resource, both preconception, post-conception, postnatally, all stages.
I was actually just going to dovetail onto the first question about milk and breastfeeding. Do you have any experience with recommending A2 milk, or is there any valid research about if they do suspect dairy as maybe not being tolerated, about A2 being a better resource for baby and mom?
Yeah, it's a great question, and as we know, the A2 herds have different makeup, and so it has been shown to at times reduce instance of reflux or GI upset. It's a little vague in terms of how the symptoms affect people. I think it's worth a shot. There's no harm that can be done in recommending that change. I think cost is always something we have to evaluate with identifying specialty milk products like that. But obviously when it comes to a milk protein allergy, though rare, that would not be a recommendation, of course. But yes, and there's been research too to show other milk types to reduce GI upset. I'm happy to talk more offline. All right, thank you so much, everyone.